I like to think of pain as different types of syndromes, not just, oh, I have a pain here. Well, what's exactly causing the pain? What organs, what tissue does it involve? And once you know that and how the patient suffers with it and the degree of their pain, you could come up with a different cocktail for each individual that you kind of sculpt for them to get the pain under control. When we go into that room, not only do we do a history, do a physical, like I would normally do on any patient, but then we have this extreme focus on ironing out what's causing their symptom, defining it as best as we can, and coming up with a mixture of drugs that we have been trained to do as a subspecialist. We feel very comfortable when using different cocktails, different opioids or narcotics to treat pain that most physicians are not trained to do or feel perfectly comfortable with. For instance, there's certain cancers. Let's take pancreatic cancer, okay, which is unfortunately a highly lethal form of cancer. It is very rarely curable. Most patients are treated with chemotherapy or radiation therapy. It is an organ that unfortunately causes severe pain, and sometimes patients have undiagnosed pain for a half a year, sometimes even a year and a half before the diagnosis was made. And it's a difficult to treat pain. It's a deep visceral organ, and this organ lays around a lot of nerves that feed the abdomen, and a lot of patients will be treated with strong opioids such as morphine, fentanyl, oxycodone, and a drug called methadone. But sometimes strong narcotics don't work for that type of pain, and you have to give something that also treats nerve pain because the pancreas lies right on a bed of nerves called the celiac plexus, and you have to add drugs that are non-narcotics like anti-epileptic drugs or certain antidepressants. When you add them to narcotics, work together or synergistically to try to control that pain. And I don't expect a lot of physicians to know that, okay? Just like as an oncologist, I wouldn't know all the degrees of heart arrhythmias compared to a cardiologist. Well, eventually a niche grows where people are truly focused on comfort measures and try things and come up with different cocktails of treatment that the average physician didn't learn. Some doctors feel very uncomfortable with the use of opioids because they don't use them enough. And that's fine and well. Then let's send it to somebody or have somebody involved that feels very comfortable with those drugs, that doesn't worry about the side effects because they know how to use them. And let me have them involved so I can forget having to worry about that because I brought somebody in that knows what they're doing there. And I think a lot of physicians are seeing that from palliative care now, and when they get a good result when they had us the first time, they're not hesitating to have us the second time and the third time, et cetera.